Good evening, everyone. We're going to give maybe a minute or more for everyone to just be able to log in, and then we'll get started soon. Okay, so we're going to get started. Thank you very much for joining in for the grand rounds. So the February was the heart month, and now it's the March. March becomes the month of the American College of Cardiology meeting. For this month and for this specific grand rounds, we have invited our um, fellows to give presentations of what would be the case presentations and podium presentations, moderated abstracts that they will be presenting at the American College of Cardiology meeting to be held in Chicago later this month. And it's a matter of great pride that if I just would share, and this is something which we have collected from the Integrated Leadership Council for the research. And what you will see is we are having total 56 presentations from all over the health system, and 20 of them come from the RWJ campus. And of these 20, I believe around 9 are being presented by the fellows, and particularly there are 5 fellows who are presenting some of these abstracts and cases. And it's also heartening to know that the scholarship and the productivity across the campuses for our health system has continued to increase year by year. We ended the year 2024 with 323 peer-reviewed publications from all across the institution. So what I would urge is our trainees and faculty, as you present them, please make sure that they get converted into peer-reviewed publications, because publications finally are the ones that make scholarship impact. With that note, I am happy to introduce our first speaker for today, and that's going to be HINA IJAZ. HINA IJAZ is a fellow in cardiology. She is in the second year, and she came in from Stony Brook Internal Medicine after completing her residency, and she had her medical training from Rutgers Robert Wood Johnson Medical School as well. And today for her presentation, she's going to present on the topic of to reverse or not to reverse multiple congenital defects leading to Eisenmenger's syndrome. Pretty rare. Hina?
Thank you, Dr. Singupta. I'm just going to share my slides with everyone. Hopefully, is everyone able to see my slide?
Yes.
Okay, perfect. So thank you for the lovely introduction, Dr. Singupta. So I'm going to be presenting my case report that was accepted to ACC this coming March, which is basically titled To Reverse or Not to Reverse Multiple Congenital Defects Leading to Eisenmenger Syndrome. So the background of this case is we're presenting a case of Eisenmenger syndrome in a symptomatic patient with infrequent previous medical contact. She's a 48-year-old female with an unknown past medical history who basically presented to our hospital in May of 2024 for dyspnea. Just some background on the patient. She had moved to the US from Jamaica about 5 years ago She reported to us a childhood history of a congenital heart defect, but she was unsure of the type of defect and she did not know the name. She endorsed that she had digital clubbing since childhood and she had shortness of breath since childhood. She recalled that in school she wasn't able to play with or keep up with the other kids because of shortness of breath, and ever since she could remember, her activity and her exertional tolerance were significantly limited. She did recall that prior to coming to the US, she saw a cardiologist in Jamaica who told her that she had high lung pressures and basically recommended some sort of corrective cardiac surgery and quoted to her a 50% mortality risk of this surgery. But unfortunately, the patient didn't know any further details about her condition. She had had 4 spontaneous abortions in the past, unfortunately, all within, it looks like, the first trimester or early second trimester at 6 weeks, 8 weeks, 3 months, and 4 months. She had an echo that was done in the outside hospital that reportedly revealed translocation of the IVC, a large PFO with intact biventricular function. We were only able to see the report of the echocardiogram from the outside institution. Unfortunately, we weren't able to see the images. And she also had a documentation of a diagnosis of polycythemia vera. She presented to our hospital with lower extremity pain and 1 week of dyspnea on exertion. For these symptoms, she went to her primary medical doctor first and was found to be hypoxic with an oxygen saturation of 80% on room air. So her primary medical doctor immediately referred her to our ED at Robert Wood for further evaluation and management. So basically, our case in a nutshell is a 48-year-old female from Jamaica who presented with dyspnea and hypoxia. Her exam was notable for a right ventricular precordial heave, very classic, as well as digital clubbing, which was also very prominent. Our echo, unfortunately, here was a suboptimal study. She did have very difficult acoustic windows, so we decided to pursue a cardiac CTA as well as a cardiac MRI. The cardiac CTA showed an atrioventricular canal defect with a large atrial septal defect, ASD, a left-sided SVC, and an interrupted IVC. Those will be shown on the figure on the next page. And her pulmonary vein was essentially draining into a large common atrium because she had a large ASD. So essentially she had one common atrium between the right and the left. It was just one common chamber at that point. She also underwent a cardiac MRI, which again revealed the large ASD, as well as was seen the left-sided SVC, which was draining into the left atrium, an interrupted IVC with a hemiazygous vein entering into the left-sided SVC, and a very extremely dilated main pulmonary artery. So this is some of the figures here, just highlighting the multimodality imaging of this case. The top are the cardiac CTA figures, and the bottom are the cardiac MRI images. I'm not sure if everyone's able to see my pointer, but you can essentially see the left-sided SVC entering here. There's a large interatrial connection and the ASD that's seen here. The left atrium and right atrium are essentially a common chamber, and we can see the left-sided SVC that's draining into the left atrium here. So the cardiac CTA, we suspected an AV canal defect with, again, a large ASD and possibly a membranous VSD as well, although this was harder to appreciate, and a left-sided SVC with interrupted IVC and a large hemiazygous vein draining into the left-sided SVC. Her coronary arteries were normal in origin and course. She had right dominant coronary circulation. Her ventricular to arterial connection was normal, so her LV output was to the aorta and her RV output was to the pulmonary artery as per normal anatomy. And it appears that her veno-atrial connections were also normal. So she had normal mitral valve location and anatomy, and also normal tricuspid valve location and anatomy. But her pulmonary vein essentially drained into a large common atrium. And then her 2 atrioventricular valves, the mitral and tricuspid, were at the same level. And she had a severely dilated aneurysmal main pulmonary artery that was seen on CTCA, as we saw before. Her cardiac MRI, the RV was severely dilated, and unfortunately her RV systolic function was also severely reduced despite her young age. Part of the RV free wall was dyskinetic. Her intraventricular septum appeared flat in both systole and diastole, indicating RV pressure and volume overload, and the large ASD was appreciated as well, as we saw in the previous image. Although only the superior and anterior rim was well visualized, it was a little bit more challenging to see all the borders of the ASD. The mitral and tricuspid valves, again, were at the same level with some slight upward deviation of the tricuspid valve with visually mild MR and mild TR. And then the pulmonary veins from both sides were draining into the left atrium. The hepatic vein was draining into the right atrium. There was a left-sided SVC that was draining into the large left atrium, or essentially common atrium, and an interrupted IVC with a hemiazygous vein continuing into the thorax and entering actually the left-sided SVC. So for that reason, her hepatic veins were not entering through her IVC, but instead directly into the atrium. And then these are just some calculations that were done based on the cardiac MRI in terms of her QPQS, and her main pulmonary artery measured as severely enlarged at 47.1 meters. So we decided to pursue a right heart and left heart cath to basically elucidate all of her right heart indices and hemodynamics, and also a left heart cath to assess for any coronary artery disease and just evaluate her coronary anatomy, given that if surgical correction of her defect was going to be pursued, she needed to have a coronary evaluation as well. So the right heart cath was very detailed. We got a lot of indices. But the conclusion was that there was a large left to right shunt at the level of the right atrium, and an even larger right to left shunt at the level of the left atrium. And that had a QP-QEF ratio of 1.57 and a QS-QEF ratio of 2.32. So essentially this patient had large bidirectional shunting, but she had a net right to left shunt. Excuse me, and the ratio on this was 0.68. And then she had reversal of shunt to net left to right with a QP-QS of greater than 1 with inhaled nitric oxide. So there was some shunt reversal with vasodilator challenging. Her baseline hemodynamics were that she had a PVR of greater than 5. I believe hers was like 7. A mean pulmonary artery pressure of 65, and a PVR to SVR ratio of about 1 with net right to left shunting. So these hemodynamics, basically, since she had developed what looked like severe pulmonary hypertension and RV dysfunction, did not support closure of her ASD defect, and then normal coronary vasculature. So our decision making basically was that her right heart catheterization showed a large bidirectional shunt, as we saw, with net right to left shunting, and reversal of the shunting from net left to net left to right with nitric oxide at the atrial level. So she was determined to have a large primum ASD with left atrial isomerism, which is an interrupted IVC and a persistent left-sided SVC, and heterotaxy with a ventricular septal defect, resulting in severe pulmonary hypertension at this stage of her life. So given her pulmonary hypertension with net right to left shunting, ASD-VSD closure was not pursued in this patient, and she was instead referred for a dual heart-lung transplantation at NBI. So just a brief discussion. In summary, we had a 48-year-old female patient. She had an unrepaired congenital AV canal defect with left atrial isomerism and heterotaxy, and had already developed Eisenmenger syndrome or Eisenmenger's physiology, as well as severe pulmonary hypertension due to her chronic bidirectional shunting, which explained her hypoxia, her clubbing, and all of those features. Hypertension means that her ventricular and pulmonary remodeling was at such a late stage that closure of this intracardiac shunt would not be favorable for the patient and would lead to a poor post-operative outcome, because her pulmonary pressures were high and her RV dysfunction was to the point where she had reversal of her physiology and reversal of the shunt, where the shunt was actually being used to offload those high right-sided pressures. So reversal of that and closure of the persistent ASD and VSD would have resulted in an unfavorable outcome, unfortunately. So in conclusion, complex congenital defects, especially ones that are not detected until a later age, adulthood, especially those that result in Eisenmenger's physiology and remodeling, are often a clinical challenge. But like we did in this case here, you should really use hemodynamic data and right heart cath indices to guide decisions regarding closure of the culprit defects via operative repair versus referral for a heart-lung transplantation. And special thank you to Dr. Albert, Dr. Donwan, and Dr. Afghani.
Great presentation, Hina. So a couple of questions that will come up from your presentation.
Mhm.
First of all, Eisenmenger is very rare, and you're correctly pointing out this is a complex defect and presumably AV canal defect. So AV canal defect means that there must be a primum, a large primum ASD with a VSD. Um, Typically in Eisenmenger syndrome, once the uh, syndrome has set in on the pressures are similar, right? And you've got bidirectional shunting going around, the QP to the QS approximates and becomes similar.
Mhm.
So we should just take a closer look at the calculation because the what this means that the 0.68 would be something we need to carefully look into. If it's like some issue with the calculation. The reason being they need to come closer to each other because that's how they become balanced circulation. So you can't. By this it means your pulmonary flow is lesser than the systemic flow. That does not happen because both the system in Eisenmenger, because they are balanced, they will have the same cardiac output on each side. So
Mhm.
we should just make sure that that 0.68 is not a numerical change that uh, because clinically you're presenting the patient is Eisenmenger, right? So that means that both the sides have same flow. It's not when you have a left to right shunt happening, then the right-sided circulation is 1.5 or 2 times the systemic circulation. But the pulmonary circulation never goes lower than the systemic circulation. It can
Mhm.
never, that's not compatible with with the cardiac function, right? So we should just make sure that we should look into that number one. And number two, another thing which is also interesting is whenever Eisenmenger sets in, particularly for people who survive into the fourth or the fifth decade, they never have dilated chambers. What is very interesting, what you point out, is the RV or the right-sided chamber is dilated. So whenever you have a right-sided chamber which is dilated with a bidirectional shunt happening, means that typically there may be still a left to right shunt going around because by default, whenever your Eisenmenger comes in, the RV is so prepared that it's like when you develop systemic hypertension, right? The LV responds by hypertrophying and becoming a smaller chamber. Uh, so the RV, when it responds to pulmonary hypertension in Eisenmenger, responds by hypertrophying, and you'd never see a dilatation. You can see rarely, but it's extremely it's not a common presentation. So that's another thing. If you continue to see, that means that there is still some residual left to right shunting happening. Uh, and that's why the RV is still slightly bigger in its size. And as the left to right and right to left becomes balancing each other, the both the chambers are similar in their sizes. Of course, there are always exceptions, but these are the two things I had my comments on. We should carefully look at.
Those are very good points.
Let us see if there's any other question. Uh, what was the change in pulmonary venous PO2 from baseline to addition of nitric oxide?
I don't remember off the top of my head what it was exactly. Um, but I do know that she did have, like we said, she did have reversal of her shunt from a net right to left, where we had the QPQS of like just above 0.5, 0.68, to left to right, where her QPQS went above 1. So her pH was determined to be vasoreactive. I don't remember the exact percentage off the top of my head, unfortunately. I
Okay.
have to look back at the calendar.
Sure. So, Hina, we will sit down and we'll go over the numbers. Was there a reduction in the PA pressure after nitric oxide?
There was some reduction in the PA pressures, yeah.
And PVR dropped down?
Yeah, the PVR I think went from about like 8 to around like 5. I think it was still significantly elevated, but based on her, it was lower than her baseline PVR.
I see. Okay. Great. Thank you very much for the presentation. We'll make some adjustments and we'll review the patient, but this is super interesting case, and typically it's not, it's very rare to see this kind of cases. So really happy that you are able to present a case of this rarity now. Thank you very much. Next, I'm going to invite ROHAN GANTI. So ROHAN came in from Boston Medical Center after completing his internal medicine. And he also did an MPH and Master of Medical Sciences at Boston University School of Public Health and Boston University School of Medicine. And for today, ROHAN is going to talk about the temporal trends in acetazolamide used in decompensated heart failure after publication of the acetazolamide in decompensated heart failure with overload ADVOR trial. And I think you might just have to change the display settings. And if you just click on that, display settings, and you may be able to go to the yes, swap the, yeah. And go to presentation mode.
Is that okay, Dr. Sengupta, or is it still?
Yeah, no, display settings. If you go into display settings, and swap the, go at the top. Okay, there you go.
Thank you. Thank you for the introduction, Dr. Sengupta. This is a research project that I'd worked on leading actually into the end of residency, into the beginning of fellowship. And as you'd mentioned, I'm presenting temporal trends in the acetazolamide use decompensated heart failure after the ADVOR trial came out. And these are my colleagues at Boston University who also were on the project with me. So just as a background, the ADVOR trial, it was a trial that came out a few years ago, and it looked at patients with acute decompensated heart failure admissions with at least one clinical and one laboratory sign of volume overload. So they looked at 519 patients and randomized it into either receiving acetazolamide or receiving placebo. And the outcomes that they looked at were successful decongestion. And to back up just a little bit, the groups that were split with the IV acetazolamide, as soon as they identified volume overload, they gave them IV acetazolamide 500 milligrams times 3 days, in addition to the baseline diuretic that the patient was receiving, which was at least IV Lasix 80 milligrams. And the placebo group would just get the IV Lasix as they were getting previously. And when we looked at the successful outcome of the trial, it did show successful decongestion was achieved in 42.2% of the patients within the trial period, and then in the acetazolamide group, and 30.5% of patients in the placebo group with a p-value of less than 0.001. So therefore, it was concluded that acetazolamide, in addition to IV loop diuretics, resulted in faster successful decongestion in that group. Most notably, it did not actually improve any mortality data when they kind of looked at it more so in the future, but it did achieve faster successful decongestion times, which led to shorter hospital length of stay. So our research question was, did the use of acetazolamide in clinical practice increase after the publication of the ADVOR trial? And why we wanted to look at this is because acute decompensated heart failure is a big public health burden, and many are invested in improving the outcomes of including hospital length, especially hospital length of stay. So the methods that we used a large database, which was the Trinetics Database Collaborative, which is a de-identified electronic health record from 89 healthcare organizations across North America. So it's the United States along with Canada. So initially, we identified about 100,000 heart failure patient encounters, and we saw that there was about 50,000 pre-publication and 55,000 post-publication. And we calculated the number of patients per 1,000 patients with outcome by month and split it up into each month. So we looked at the month previous to publication and the month after publication, 5 months. So January, February, March, April, et cetera. The trial came out in roughly September, and then looked at the 12 months after. And we used interrupted time series to quantify changes in outcomes. And just as a refresher, interrupted time series looks at, okay, was there after an intervention was performed, or public health, a law was made or something like that, what are the trends looking prior to the intervention and the trends after? And when we did our analysis, we emulated the ADVOR protocol, and we took the inclusion criteria of inpatient heart failure encounters. They had received loop diuretics a year prior to hospitalization, and they were admitted from this period of August 21st to August 2021 to August 2023. And that trial came out and was published in New England Journal of Medicine around August 2022. So for our results, we looked at baseline characteristics, and the average age of our patient cohort was at 72 years. The BNP average was 1,927, and the inclusion criteria of ADVOR included all patients, included the minimum BNP inclusion criteria was 250. The NT-proBNP was 15,000, and the serum bicarbonate on average was 26, and this was not different between both groups. And so when we looked at our results, we analyzed acetazolamide use per 1,000 patient encounters, and we actually looked at within 3 days of admission, as ADVOR did look at, and then we also wanted to take a look at acetazolamide use within 7 days of admission as well. So if you look at the graph here, and you look at the 12 months prior to the ADVOR, so ADVOR was the study month, which is represented by the black horizontal line here. You saw the change in acetazolamide use in at least within 3 days and 7 days of admission is essentially flat. And it's roughly about 12 patient encounters per 1,000. Once ADVOR came out, which was right here, we saw it's pretty significant jump, immediately changing of 6 uses of Diamox per 1,000 patient encounters. And we saw an even larger jump of roughly 13 within 7 days of admission. After the trial came out, it looks like the use of Diamox or acetazolamide, it's sustained, but it did not further increase per month. It also more or less kind of leveled off. And then when we look, we did calculate adjusted and unadjusted data, adjusted for the mean BNP, mean proBNP, age, and serum bicarbonate, and the results were roughly similar. And so from our analysis, in our large observational cohort analyzed with interrupted time series, we did find a statistically significant difference in the primary outcome of use of acetazolamide within 3 days of admission. And then we also saw that there was a significant increase initially of acetazolamide within 7 days of admission. There was a larger increase in the use of acetazolamide within 7 days of admission, which was outside the context of the ADVOR trial protocol. Although I'm going to back up one slide, although we did see a significant increase, the overall use of acetazolamide, from our analysis, was overall quite low. And so our conclusion was, although despite that there was an increase, future studies should seek to further address the use of acetazolamide within the early and late trial period. So the way that ADVOR looked at it, and also after within 7 days, and looking at associations between acetazolamide adoption and patient outcomes as well, because that's not something that necessarily we were able to kind of look at. And so it's brief, but I wanted to kind of thank everyone here, and also thank my mentors at Boston University who encouraged me to kind of do this analysis and kind of dip my feet into the research space.
Thank you, Rohan, for a very strong presentation. I think your data was very unique. I haven't seen. How did you come across this conceiving this study?
Well, it's a great question. When we were in residency, we always, I think there's, I guess, pressure, like kind of from hospital administration, from the cardiology, and we saw so many patients with heart failure exacerbations that it would, be like, 5 or 6 of our 16 patients that we had on the medicine floor. And so we would try and use kind of anything and everything to help these augment diuresis and help these patients decongest faster so they could leave the hospital. So when this trial had come out, there was, at least on a residency program, there was quite a big buzz. And we did try and use Diamox for all the patient encounters that met the inclusion criteria. So once we did this, we did anecdotally potentially observe that this was the case. The patients may have had a faster decongestion time, but just because of that, it kind of got myself and my colleague a little bit curious on what the practice patterns were across the country on if people were actually adopting this trial or if it was something that wasn't really adopted. So it was more built out of curiosity of what we were seeing on the inpatient floors.
And my knowledge on the use of diamoxin in heart failure is not very contemporary, so I might have to relate to you. What have you seen in terms of the practice pattern, and what impact does it do in terms of outcomes in heart failure?
So the ADVOR trial, the one thing they did see that they had faster decongestive times. I actually discussed this with Dr. Dolno as well when we were on the heart failure service, but it didn't actually show a significant difference in terms of mortality or actually a significant difference potentially in 30-day readmission rates. And so I think, everyone was very excited about this trial the second that it came out. But then afterwards, I think the excitement got a little bit less. Another notable thing about the trial was, although the inclusion and exclusion criteria are quite liberal, they did have an exclusion criteria, which we kind of realized later, and when we're submitting this, mentioning this in the discussion. But exclusion criteria was SGLT2 inhibitors, and now SGLT2 inhibitors have become a pillar of HFpEF and HFrEF treatment. And so that is something that's kind of notable about this trial, and maybe that's why we saw that they didn't have kind of persistent uptake of the trial.
All right, and we all know about the diuretics typically are more symptomatic benefit rather than basically making bigger impact on outcomes, particularly for major adverse cardiac events. It typically does not change. So I'm not surprised that your rehospitalization rates are not impacted. But obviously, I'm curious how, with so many medications that now are being prescribed, what does it mean in terms of patient compliance? And I worry considerably about how much patients typically can abide by with such a large list of medication that they are required to. I think this is an open-ended question, but guideline-directed medical therapy is perhaps the most impactful in terms of clinical outcomes, and it has a large impact. But at the same time, optimizing the number of the therapies so that people can realistically achieve their therapeutic regimen compliance remains a larger question.
Of course, yes, agreed.
All right, great. Thank you very much for your focused presentation, Rohan. So good luck with your presentation at the ACC. And now I'm going to go ahead and invite NOREEN SYED. NOREEN came in from Zucker School of Medicine at North Shore University, LIJ, where she did her internal medicine and also was working as a hospitalist. And for today, NOREEN is going to present on the approach to the management of immune checkpoint inhibitor-induced myocarditis versus acute viral myocarditis. Very interesting question. Looking forward to it, NOREEN.
Thanks so much, Dr. Sengupta. Let me share my screen.
So you'll have to just go and just swap it. Perfect. Just click on once on that. That's great.
All right, so thank you again, Dr. Sengupta. So the title of my abstract and my presentation is Approach to Management of Immune Checkpoint Inhibitor-Induced Myocarditis versus Acute Viral Myocarditis. And I worked on this with Sean, who's a third-year cardiology fellow, and then Dr. Dolno. So I'll just kind of breeze through the case just for time's sake, and then we'll kind of get into the details of what we're talking about. So we had a 26-year-old female with a history of Hodgkin's lymphoma, currently undergoing treatment with Pembro GVD, history of a PE, and who had completed treatment, no longer in anticoagulation, anemia, type 2 diabetes, and asthma. She had initially presented to an outside hospital in April with upper and lower extremity pain and swelling and a non-productive cough. And just to give a little bit of background on her Hodgkin's lymphoma history, so she was initially diagnosed with classical Hodgkin's lymphoma
In June of 2023, when she had presented with some respiratory symptoms and was found to have an anterior mediastinal mass. She underwent first-line treatment for advanced classical Hodgkin's lymphoma with VV-AVD for 6 cycles. So she had gone through 6 months of this treatment. But unfortunately, on PET scan, she was found to have refractory disease. She was then started on second-line therapy with Pembro-GVD, which is pembrolizumab, plus gemcitabine, vinorelbine, and liposomal doxorubicin. She completed 3 cycles of this. And a week prior to presenting to the outside hospital with her complaints of upper and lower extremity pain and swelling, as well as a non-productive cough. So when she presented to the outside hospital, she was found to have a high sensitivity troponin T of 14. And then actually it's not pro-BNP, it was a BNP level of 170. And elevated inflammatory markers, ESR 67 and CRP 7.2. Her EKG, which showed sinus tachycardia with some poor R-wave progressions, non-specific changes that were really non-contributory. And her echo at the time showed a small pericardial effusion, but was a normal EF, no wall motion abnormalities. And then an elevated RVSP of 44, which at the time was attributed to likely an undiagnosed sleep apnea, causing pulmonary hypertension, as well as her history of asthma. During this hospitalization, she also underwent a CTA-PE, which was negative for PE, showed a stable anterior mediastinal mass, and then also had findings concerning for hypersensitivity pneumonitis versus pneumonia. And then just for kind of completely safe, she also underwent a lower extremity duplex, which was negative for NTDT. So her clinical course at this outside hospital, she had presented with signs of volume overload. She was started on some diuretics. She was found to be pancytopenic during that hospitalization. She was requiring transfusions. She also developed a fever. And then in the setting of this pneumonitis/pneumonia seen on the CAT scan, she was started on steroids and antibiotics, and then actually transferred to RWJ for a bronchoscopy, actually. When she got here, she actually was found having improving symptoms. The bronchoscopy was deferred. She was being treated with antibiotics and kind of like lower dose steroids. And then her RVP was found to be positive for human rhinoenterovirus. But here, from a cardiac perspective, she was evaluated by the general cardiology team, in the setting of being on an immune checkpoint inhibitor and coming in. She underwent an echo in our system, which showed that she had mildly depressed LV systolic function with an EF of approximately 53.5%. She was also noted to have abnormal diastolic function, elevated evidence of elevated filling pressures, and then abnormal global longitudinal strain, which was 14%, normal being above 16% generally, normal RV systolic function, and then no pericardial effusion. So in light of having, some abnormal cardiac biomarkers, and then an abnormal echo, she did undergo a cardiac MRI to evaluate for myocarditis, and her MRI did come back positive for myocarditis. And so the findings showed that there was a small pericardial effusion, mildly reduced systolic function, mild global hypokinesis, and an EF of 45%. There was evidence of interstitial fibrosis. The T1 was elevated. The ECV, which is another T1 marker, was also elevated. T2 was elevated at 84. There was no LGE. And that was really it for the cardiac MRI. These are some kind of images from her cardiac MRI. So on the left, the orange kind of map, that's the T1 map. And if you look at it, the normal T1 number should be less than 1,000 generally. And you can see a lot of hers are 1,100 in the low thousands, so definitely abnormal. And then in the middle, the more purple pink colors, that's the ECV. Those numbers are also elevated and abnormal. And then on the right, you can see the T2 kind of characteristics. We couldn't get a good T2 map image, but these numbers should generally be like closer to 50, 55. And you can see her mean is 75.2. So clinical course for this patient. So due to clinical suspicion and her cardiac study suggested of myocarditis, patient was treated with high dose pulse dose steroids and subsequently with a steroid taper. She was also started on GDMT as well as maintenance diuretics. And her ICI therapy, immune checkpoint inhibitor, the Pembro, was discontinued, and she ultimately underwent beam therapy, followed by stem cell transplant and radiation. She was followed in heart failure clinic. She's had multiple echoes since then, which revealed that her EF, her moderately reduced EF has been stable and with clinical improvement. So that was kind of her clinical course. Then now to just kind of get into what ICI-induced myocarditis is and how we kind of approach it. So what are immune checkpoint inhibitors? So they're monoclonal antibodies that target the host immune negative regulations receptor. So if you just look at the diagram on the right here, there's kind of three main targets that are 7 FDA-approved ICIs kind of target. So I don't know if you guys can see the mouse, but at the very top you see the CTLA4, which is something that's it was one of the checkpoint inhibitors on the T cell, as well as the PD-1 and its 2 ligands, PDL1 and PDL2. So for Pembro, it's a PD-1 receptor antagonist, so that's what we use. And so ICI-induced myocarditis. So it's one of the many different immune-related adverse events that can happen when using these like novel immune checkpoint inhibitors. But it's one of the more rare ones. The reported incidence is like 0.04% to 1.14%, which is much lower than the incidence of the other adverse events that happen. But unfortunately, the mortality associated with it is much, much higher, like an associated mortality 25 to 50%. And the interesting thing about it is if it increases when you have other adverse events happening. So for example, if a patient presents with colitis or pneumonitis and stuff, you're more likely to see myocarditis with it. And the timeline of it is that it generally occurs in the first 1 to 2 months after starting the ICI, and then it can be suspected even after just like 1 to 2 doses of the immunotherapy. And then the the spectrum with which patients present is an ACS-like presentation, acute heart failure, chronic heart failure with different levels of severity. And this is very similar to the way that viral myocarditis also presents. You can often have a concomitant pericarditis or pericardial effusions. And one thing to kind of note out is you must exclude ACS as risk factors for malignancy, often overlap with risk factors for CAD. And kind of just going through just repetitive on the left side, kind of the degree of symptoms going from asymptomatic to severe. Kind of increase your need for diagnostic testing interventions. And generally the diagnostic evaluation, you would want to get cardiac biomarkers and EKG and echo kind of baseline for all of these patients where you have any level of any index of suspicion. But then as you go through, you would want to get an ischemic and non-ischemic evaluation. Cardiac MRI is really kind of standard of care, and then myocardial biopsy is kind of the gold standard for diagnosis of myocarditis. So just some things to point out with the cardiac MRIs, there's a modified 2018 Lake-Louise criteria that's used. So there's the main criteria, so you have your T1 kind of findings, and then you have your T2 criteria, so you have to have one of each, and which our patient did. They had increased native T1 and they had increased ECD, and then as well as evidence of myocardial edema where we had elevated T2. And then as well as other supportive criteria. These are not diagnostic, but they can kind of help guide you in the right direction. So if you have pericarditis or evidence of pericardial effusion, which we did for our patient, or evidence of LV systolic dysfunction, which again we did for our patient. And then, like I mentioned, the endomyocardial biopsy is the gold standard for diagnosis of any myocarditis. And the two main components that we're looking for are inflammatory infiltrate and myocardial necrosis. And then just kind of to address the management. So, kind of the way that you manage this is with steroids. Generally, there's no complete consensus on how long the steroids need to be prescribed for, exactly what the dose would be, but general consensus is that you would want to do 1 mg per kg daily for approximately 3 to 5 days, and then taper that. It would be like a slow taper. And for viral myocarditis, it's usually a longer taper, and then for ICI-induced myocarditis, it can be a 4 to 6 week taper. There's also studies that show that maybe troponins can be used to kind of monitor the response. And then really the management is similar to viral myocarditis, where there can be like other, if you're refractory to steroids, so you can use IVIG, plasmapheresis, as well as other agents. But to kind of circle back around to the big question here is why this patient was treated for ICI induced myocarditis versus viral myocarditis, or why that kind of direction was taken, is because kind of the clinical course of ICI myocarditis can be much more fulminant than viral myocarditis. And in this case, the clinical presentation matched up much better with the ICI myocarditis. And I think the decision to kind of treat it as such and not pursue an endomyocardial biopsy was kind of twofold. One, that the endomyocardial biopsy wasn't necessarily going to reveal kind of any additional information that would change the management in this patient. In particular, I think the findings would still have like lymphocytic predominance in both. So I think the treatment would have been steroids for both. And I think that the second thing was that I think the way that you kind of approach this is kind of like the timeline of how things kind of presented, and the patient tested positive for rhinoenterovirus, which doesn't usually cause myocarditis. All right, I think I might be over my time here, but thank you. Any questions?
Thanks, Noreen. So I think very important topic of immune check point inhibitor myocarditis. One point I wanted to just make sure that in our, I think you covered it later on. I think you mentioned somewhere a suggestion in the MRI report of fibrosis. I would assume that that's probably not the right interpretation, because what we are looking here is the T2 criteria, which is myocardial edema, or T1 criteria, and extracellular volume expansion. So basically, in all of these conditions, histopathologically, there is more of an edema and infiltration of the myocardium rather than fibrosis. So I want to just make sure that you look into that. If there are anybody from MRI or anyone else wants to make sure. So that point of there is evidence of interstitial fibrosis, I wouldn't know if that is basically can be interpreted, because extracellular volume expansion here, it could be not necessarily fibrotic element. It could be just an infiltrative element because it's a myocarditis kind of picture. Yeah, I think Yasmin, is that Yasmin? Or
No, this is cool. And I'm sure Yasmin is there. Yasmin, you can go first.
So I just kind of wanted to clarify the terminology. So yeah, of course. So we so there's replacement fibrosis and there's interstitial fibrosis. So T1 goes up whether you have interstitial fibrosis or if you have edema. Both increases your native T1 value. It's in general, if your native T1 and ECV is elevated, we do use a terminology global, not interstitial fibrosis, but not replacement fibrosis. If there is LGE, then it's replacement fibrosis. So that's the standard terminology in MRI.
Yeah, but I mean, won't it be? I mean, what I'm trying to say, based upon the scenario here, right? It is more of the interstitial compartment which is expanding, right? And because of, I mean, some form of infiltrative or myocarditis-like process acutely. Because how would you have a fibrosis acutely, right? I'm just questioning that. Number one. Number two is. I know that the Lake Lewis criteria may not be completely fulfilled because you cannot I mean you would need LG to talk about necrosis, right? There's no myocardial necrosis. I think there was no LGE in this patient, if I understand correctly. Then how comfortable are we in terms of using it as a myocarditis, or we call it as a myocardial injury?
So you don't need to have LGE for sure. So you have to have one T1 criteria and one T2 criteria. And that T1 criteria could be either elevated native T1 or your LGE, but not both. Both are not necessary. So you could have elevated T1, but no LGE. You do meet one criteria. On top of that, you have to have one T2 criteria, which could be elevated T2 MAP or your T2 stir. So that fulfills the criteria. You do not need to have LGE for it to be a myocarditis.
Yeah. And then was a biopsy done?
No, there was not.
And what was the course after? Did the patient respond?
Yes, they did.
Okay.
Hi, this is Lance Berger. Can I make a couple comments?
Yeah, please. Go ahead.
So I'm a cardiologist in Tom's River, and I have some interest in this area. And I want to thank you for a tremendous presentation. Very well done. This is as you all may know, checkpoint inhibitors have become a pillar of care for our oncology colleagues. And although this is rare, as you pointed out, it can be fulminant and fatal. And I've actually seen cases of this. The cases like this can be challenging because you have a couple of competing issues, number one of which is the doxorubicin. So how do we know when we walk into a case like this that this is not doxotoxicity and this is actually the checkpoint inhibitor? Your patient had the Lake Louise criteria for myocarditis, and that's pretty convincing to then decide to use the steroids, which you appropriately did. So I think that that was very, very well done. There's another, I just want to highlight a couple of things. Number one is early institution of high dose steroids is very important for outcome. And so you reacted to this very quickly. You jumped on it right away. And so early treatment is really important. And I would encourage everybody listening that when you're seeing patients who have checkpoint inhibitors, that we keep this as a very high index of suspicion when they have any sort of cardiovascular symptoms, chest discomfort, shortness of breath, palpitations, because it can present like anything. And I would also encourage, I've encouraged our oncologists in Tom's River that a baseline troponin may be helpful for delineating some of these folks before they get treated with checkpoint inhibitors, because how do you interpret a very mild troponin elevation in a 70-year-old lymphoma patient who can have chronic ischemic heart disease or other cardiovascular issues? So I think this is, and you're going to see more and more of this, and I think this was very well done. And I congratulate you on a tremendous clinical outcome and a tremendous presentation. Thank you for this.
Thank you
so
very much. I know that there are lots of exciting questions. This is going to be more common, and cardio-oncology, as Dr. Nidhi Tripathi is developing the plan to launch it with our new cancer center coming up. as the director of the cardio oncology program. We're going to have more and more discussions around this. So thank you, Noreen, for presenting this. And I know that I think, Kamu, you had a quick comment. Do you want to quickly say that, and I'll go to the next presentation?
Oh, no, this is going to be really quick. Just reinstating that interstitial fibrosis can be seen in the setting of edema, and this can be not replacement fibrosis, but just collagen that is kind of broken, which is why when you have a little bit of ECV that starts creeping up more than 36%, then you start thinking along the lines of interstitial fibrosis. And it is loosely utilized, but when you actually do biopsies in these patients, you can actually see that the collagen fibers are broken and they're just very edematous. The second thing is, a lot of times when it comes to cardio-onc, we actually look at 17%. Each lab sets it differently, but at least negative 17% as the cutoff for GLS. And I do have to agree with Dr. Landsberger saying that having a baseline troponin is always good before they start any ICIs like Pembro, because if this myocarditis happens, the mortality can be upwards of 50%, and this can be something, I mean, we might lose patients. So I think we typically ask cardio-onc people to actually get an echo and look at GLS, as well as also get a baseline troponin and BNP. So just those couple of comments. Thank you.
Great. Thank you very much. Thank you, Noreen. We're going to move on with our next presentation. It's going to be by TAHREEM IQBAL. And TAHREEM came from University of Maryland in Baltimore. And it's interesting to note that she also had, besides her internal medicine, a fellowship in advanced heart failure at Alabama, Birmingham. And today she's going to present a talk on cardiac fibroma, rare tumor with some complex decision to be made. TAHREEM.
Thank you for that introduction, Dr. Gupta. Can everyone hear me?
Yes.
Okay. So my presentation is on a case report on a patient with a known cardiac fibroma. So the patient is a 57-year-old woman. She had a diagnosis of cardiac fibroma back in 2010 when she initially presented to the hospital after a syncopal episode. For this most recent hospitalization, she presented with substernal exertional chest pain with radiation into the neck and left arm. That was different than her chronic chest discomfort. And she also had some dyspnea on exertion and peripheral edema. Her past medical history included anxiety, depression, bipolar disorder. She also had a sternotomy with an aborted tumor resection 14 years prior at the time of diagnosis. On admission, her troponin, her high sensitivity troponins were negative. They were 8 and 7. EKG was normal sinus rhythm with first degree AV block and nonspecific STT wave abnormalities. Her primary cardiologist saw her in the hospital and recommended starting off with a Lexi scan, an echo, and when advanced heart failure saw her, we also recommended getting a cardiac MRI. The Lexi scan showed a stable fixed perfusion defect of the mid to basal lateral and infralateral wall of the left myocardium, which had been stable since 2017. The echo showed the cardiac mass, but it required further characterization on the cardiac MRI, and it basically showed a large, well-circumscribed intramyocardial mass measuring 5 by 7 centimeters on axial images located in the lateral wall of the LV, and it was surrounded by pericardium, and there was some small compressive effect on the LV cavity. All in all, the cardiac MRI was suggestive of a fibroma. And usually for a cardiac fibroma on MRI, usually you'll have a hypo-intense lesion on T2 weighted MR images. and ISO intense relative to muscle on T1 weighted images. It's usually a homogeneous structure, but every once in a while you can see calcifications within the mass itself on cardiac MRI. There is usually little or no enhancement with contrast due to these structures being avascular, but there might be a delayed hyperenhancement about 10 minutes later, since they have a large extracellular space component. So these are the images of the, so the top row is the CAT scan, and as you can see the mass here. But then you can see on the cardiac MRI in the steady state free pre-session images in short axis, you can see this intramyocardial mass about 5 by 7 centimeters in the lateral wall of the LV. And you could see some of it on echo as well, but it obviously was better characterized on the cardiac MRI and really allowed us to kind of hone in on that this was most likely a cardiac fibroma. And it was relatively similar in size to what it previously was about, I think like 10 years prior on imaging studies she had at that time. So just a review of cardiac fibromas. They are rare, usually benign. They're rare benign primary cardiac tumors. They can be congenital. They can occur anywhere in the LV, intraventricular septum, RV, but they're usually in the free wall of the LV and the ventricular septum. They're usually solitary. Oftentimes they can be large. They can be multilobulated. They're usually unencapsulated and tend to be adherent to the surrounding myocardium. And sometimes they can even infiltrate the normal myocardium. People are usually asymptomatic, but at times you can have serious complications, and those complications tend to be heart failure, arrhythmia, sudden cardiac death. From a histologic standpoint, they're usually like a bland spindle cell fibroblastic cell proliferation with collagen. Usually cellularity decreases while the collagen increases with age. I mentioned before, occasionally you can have calcifications. Sometimes you can have aggregates of lymphocytes and histiocytes. Sometimes you can have necrosis and ossification within the mass itself, and sometimes it can infiltrate into the surrounding myocardium. So sometimes you can see isolated islands of entrapped myocardium. So this is just some histologic slides, not from this patient, but as you can see the myocytes surrounded by collagen. And this is another example of basically there's entrapment of the cardiac tissue between the collagen of the cardiac fibroma. This is just another example of that. In general, there are a few, I guess, observational studies, retrospective case series in which they've taken a look at individuals who have cardiac fibromas. There was one such case series done in 1994. It was a case series of 23 patients. The mean age was 13. The range was 1 day to 56 years old. In general, some patients had no symptoms. The patients who did have symptoms had symptoms of heart failure. They had chest pain, arrhythmias. So they were kind of characterizing that oftentimes it was also associated with Gorlin syndrome, an autosomal dominant inheritance pattern. They noted that there were some unfavorable prognostic signs, which included younger age at diagnosis, involvement of the intraventricular septum, a large tumor burden, and diffuse myocyte interdigitation, because in those situations, in particular with interdigitation, there's increased risk of sustained arrhythmias. So the treatment was either surgical resection or excision, and heart transplant could be considered and performed. especially for large tumors that might not be amenable for surgical intervention. And in terms of surgical resection of these tumors, there's a retrospective review of 18 patients that was done of patients between the years of 1964 and 2002. They had a variety of presenting symptoms. Some were presented with syncope, some with angina or chest pain, one with cardiac arrest, some with heart failure, dyspnea. 17 of the patients had total complete resection, and one had a subtotal resection of the fibroma. Most of the tumors were located in the LV, with 4 of them located in the septum, and one was in the RV, or 2 were in the RV. There was one infant, 2-month-old, who died intraoperatively, but they were able to follow up the rest of the 17 patients. And follow-up consisted of reviewing medical records and conducting written correspondence or telephone calls. Total follow-up lasted for up to about 33.7 years. There were no late deaths or complications that they found in these 18 patients. And none of the surviving patients had any complete heart block post-operatively. This is just some characteristics of where the tumors were located of all 18 patients. And in general, you can see that there was a lot of range in ages. So our patient had a 5 centimeter by 7 centimeter mass. And so as you can see, there were patients who had similar size masses who underwent either complete excision or one underwent just a resection. On follow-up, most of them remained asymptomatic, about 14 of them. There was no tumor recurrence after complete resection, and there was no change in size of the residual tumor in the individual who had a subtotal resection. And so they concluded that most ventricular fibromas, even if they're extensive, could potentially be managed operatively via resection, whether that was total or subtotal, with good long-term outcomes. For our patient, she previously, in 2010, when she was initially diagnosed with this fibroma, she had been referred to many different cardiac surgeons, and they even did a sternotomy, but they had to abort it. It was unclear exactly why. The way she described it was that I think perhaps it was when the surgeon opened up the chest, they might have realized it was more extensive than they might have anticipated. And so they ended up not even, I don't even think they biopsied. I think they immediately just aborted, closed up the incision. And then since then, she's kind of just been living with this chronic chest pain, but more recently was starting to have more heart failure type symptoms. She ultimately was deemed not to be a advanced therapies candidate. I think there were like multiple issues as to why. I think maybe some of it might have been psychiatric that kind of precluded her from being considered for cardiac transplantation. And so I tried to find out exactly what happened after she was discharged. I don't think she's following up within the RWJ Barnabas system. But basically she was diuresed. We got her symptoms to be improved, and we had our CTS colleagues comment as well, and they didn't feel comfortable going after like a reduced sternotomy with attempt at resection, especially if there was another surgeon who felt uncomfortable doing it. So, any questions?
Wow, that was very rare. I mean, most of the fibromas, they are typically in children. Like, I mean, you see rhabdomyomas and fibromas, and you know, your tuberous sclerosis. I mean, that Gallin syndrome that you described. It's never seen in this kind of elderly individual. So if you want to just come off your screen, and we can just
Oh,
see.
stop share.
Yeah, unshare your screen. Yep, perfect. Now you're in. So any quick question for TAHREEM? I'm just perplexed how late presentation she has. But one of my question is like, so you don't have a histological data to confirm it's fibroma. Why could it not be something else like a rhabdomyoma? Which is typically not seen in adults, but so is
Yeah.
fibromas. But
I'm not sure. I imagine it was probably, I don't know if I don't know if it's more vascular maybe. And maybe that would have been seen more on the cardiac MRI, but I'm not quite sure.
anybody from the imaging from MRI? I don't think rhabdomyomas are also more vascular. I think they are typically they're very close in their differentials. Both of them look like masses arising from myocardium. But obviously, rhabdomyoma is very, very uncommon in adults. It's mostly in children. But interesting. And no conduction abnormalities, no arrhythmias, just interesting.
No, I don't remember her having any significant arrhythmias, no.
All right, so great presentations from all our fellows. All the best. Make sure that you have your slides looked through with tooth and comb so that there are no errors in data. And I think in general, you have all done a great presentation. I wanted to also make sure that everybody knows that next week's presentation on the 10th, the American College of Cardiology president, the current president, Kathy Biga, is going to be on site. And it's going to be in person meeting. It will be a very prestigious session for us to host the ACC national president on site. So we look forward to everybody's engagement. And please come prepared with your questions. And also please look forward to meeting you all at the ACC with all these brilliant presentations that you all compiled together. With that, thank you very much, everyone, for joining in. And we look forward to seeing you next week. Bye-bye. Good night.